Good evening, one and all present here. I am Harsha here from Science Integra, and I welcome you all for the 13th episode and series 2 of Maha Smiles Cleft Care for Every Child. I would like to introduce you all to Miss Renu Mehta ma'am, who is the Area Director of Smile Train India. Over to you, ma'am.
Good evening, everyone, and thank you so much, Harsha. You have done the introduction that this is the series 2 that we are having with the Foxy group. You may all know by now that Smile Train is the world's largest cleft-focused NGO, and we support safe and quality cleft care for children globally, enabling them with the opportunity to live full and healthy lives. In India, we work through a network of partner hospitals. Currently, we have 125 across the country. And over 2 decades of us working here, we have supported over 740,000 cleft surgeries. Smile Drain has been in collaboration with Foxy since 2019, and we are extremely grateful for this partnership. Today is another webinar in the series, and as you all know that we are focusing on the state of Maharashtra. For us, this is very, very special. This is Maha Smiles, Cleft Care for Every Child. Maha Smiles is a CSR collaboration between Bajaj Finserv and Smile Train India. And through this collaboration, we aim to build awareness and support treatment to children who are born with cleft in the state of Maharashtra. And with this partnership with the Bajaj Finserv, we will be supporting 8,000 life transforming cleft surgeries in a period of 36 months. And we will be creating awareness for the timely treatment. And we will be sharing through our various experts the timelines of cleft care. Currently, we have 12 treatment centers across the state of Maharashtra. And if you find any cleft child, please, or a parent of one, please connect them to one of our nearest partner hospital. We also have a toll-free cleft helpline. Our further information is available on our website, smiletrainindia.org. And our toll-free number is 1-800-103-8301. And today it's my privilege to introduce Dr. Monica and Dr. Supriya. And I'm going to hand over to Dr. Monica now to take this forward. Thank you so much.
Thank you, Renu ma'am, for updating us about the work done by the Smile Train project. It is indeed a pleasure to be associated with you both at the Foxy and the AMOGS level. We are also thankful to AMOG's office bearers, Dr. Kiran Kurtukoti sir and Dr. Bipin Pandit sir, for allowing us to conduct these sessions so that all the obstetricians and gynecologists across Maharashtra are sensitized for this topic. After the formal inauguration, we will take blessings from our guest of honor, Dr. Parikshit sir, today. He has been my mentor and teacher since from my undergraduate and postgraduate days. He is currently the treasurer at Foxy. We welcome you, sir, today for your blessings, sir, today.
Thank you, Monica. Yes. So I think you are doing a wonderful job. When we are looking at public awareness, I think before the public becomes aware, even doctors and gynecologists need to be made aware that there is such a wonderful service which is available for children and adolescents who are affected by this problem. See, cleft lip and cleft palate are not considered as lethal anomalies, but they do seriously affect the quality of life that a child who is born with this problem will have. And it's very, very important that parents be made aware, along with the treating doctors, the people whom they are going to consult at the outset. I mean, typically, it might be the obstetrician who first breaks this news or first notices. Sometimes it may just go unnoticed and we see this at birth. So if the obstetrician is aware that this is treatable in this particular manner, I think the counseling outlook that the couple will receive from that point onwards will be different, and it will be with the understanding that this is potentially treatable. So I think it's a great meeting today. It will sensitize all of us obstetricians in terms of this problem. And I must congratulate the Smile Foundation for all the work that they are putting in through the partner hospitals and care sites for the wonderful correction and work which is going on. So my congratulations to Smile Foundation and for Monica for bringing this program to all of us.
Thank you so much, sir. Your presence definitely is a boost to all, the confidence that I and Dr. Supriya get as conveners for this program. Thank you for your blessings.
Yes, of course. Supriya, nice to see you. And I've been in touch with Monica, so forgive me for not mentioning your name at the outset.
Thank you so much, sir, for being there. Dr. Kiran sir will join after his emergency surgery is over. So I think we can proceed with the academic program, and I would like to invite Dr. Pratibha Baldava as the master of ceremony for this program. Over to you, Pratibha. Unmute yourself, Pratibha, please.
Okay. Welcome everyone. Am I audible now?
Yes.
Okay. I welcome all of you all again for this wonderful session on Smile Train again. And I invite the chairpersons for session 1. Can I have the slides, please? Harsha, can you put the slides? Yeah. Okay, the first chairperson for session 1 today is Dr. Geeta Palsarkar, madam. She is a very well-known teacher at Wadia Hospital, and I have also been trained under her. She is editor emeritus of Journal of Obstetrics Gynecology of India. She is secretary of MOGS, president Association of Medical Women in India, and president Menopause Society. She is also a chairperson of Young Talent Committee, FOXY, and recipient of many prestigious awards. She is a professor at CGS Medical College in Naroji Wadia Maternity Hospital. All of us know her well. I welcome you, madam.
Thank you.
Next chairperson, CV, please. The next chairperson for today is Dr. Ujjwala Bardapurkar. She is a postgraduate from BMMC Solapur, and she is a director of Yash Nursing Home and Sonography Center, president of IMA Bhiwandi for the last 5 years, working committee member and secretary general of Thane OBGY Society, and she is a convener of MPH IMS MS. She has received many awards. The most prestigious among them is President Appreciation Award for Maharashtra State IMA 3 times, and many other prestigious awards. She is Medic Queen Excellence Award 2022. I welcome you on board, Dr. Ujjwala. Madam, are you there? Dr. Ujjwala, madam?
Ujjwala ma'am and Rajendra sir will join shortly. Till I will request Geeta ma'am.
Yeah. Okay, we can ask Geeta madam to start the session by then.
To introduce
Rajendra Tiwari, sir, please.
Okay, next slide, please. Dr. Rajendra Tiwari, sir, he is Director of Shri Maternity and Nursing Home, Joint Secretary of IMA Maharashtra, Joint Secretary of AMC Mumbai, Secretary Palghar OBGY Society, Committee of Mender IMC Self Foxy, Committee Member of Palghar District MTP Committee, Committee Member of Palghar District Negligence Committee, and he is an ex-chairperson Medical Legal Cell IMA Maharashtra Board. He has received many awards. He has been a faculty at national and international conferences. I welcome you, Dr. Rajendra, sir.
Thank you, ma'am. At the outset, I thank all the dignitaries present on this forum and AMOS as well as the national organization for giving me opportunity to share my views on this topic in this elite webinar. Now, I think without wasting time, I'll just go to the topic. My screen has been shared.
Yes, sir. It is visible.
Today's topic is missing fetal anomalies. On the ultrasonography. Dear friends, as we know, all of us are conducting sonographies. Many of us, in fact, obstetric sonographies, many of gynecologists we are conducting. And ultrasound has revolutionized the practice in the OBGYN. Obstetric sonography, however, plays an important trigger factor for medical legal suits in the OBGYN practice. Though it is common, it is one of the important trigger factor for filing medical legal suits against the OBGYN practitioners. All major anomalies, they account for about 2% of the pregnancies, but they need to be diagnosed at appropriate gestational age in order to prevent further problems. Now, some major anomalies I'm going to enumerate. This list is just neither exhaustive nor comprehensive. It is just an elaborative list of few of the anomalies which are common. Some CNS anomalies like anencephaly, acrenia, encephalocele, holoporencephaly, ACC, agenesis of corpus callosum, Dandy-Walker malformation, gross hydrocephalus, huge cystic hygroma, chest abnormalities like diaphragmatic hernia, heart diseases like TOF, anomalies of abdomen like omphalocele, gastrocystis, proximal GERD, atresia, renal agenesis. There are so many skeletal systems anomalies, etc. But one for diagnosing the anomalies, screening at appropriate time is also important. Now, for example, omphalocele can be best visualized only after 12 weeks. DVM, that is Dandy-Walker malformation, it cannot be well diagnosed before 17 weeks of gestation. Renal, skeletal, and GIT abnormalities show up as late as 28 to 34 weeks. Hydrocephalus due to aqueductal stenosis can appear as late as 32 weeks. Why I am telling this? Because many of us are doing sonographies only at 18 weeks, anomaly scan and NT scan, standard things are there. So there can be certain anomalies which cannot be recognized at that particular duration, and they can be recognized late also. So informing all these, keeping eye on all these things is very important if one wants to avoid the medical legal suits due to negligence as a result of missing anomalies on sonography. Now, first of all, today we are dealing about negligence when one misses certain anomaly on the sonography that we are discussing. Before that, we should know what is negligence. Dear friends, negligence is omission to do something which a standard and reasonable person would have done, or doing something which a standard and reasonable person would not have done. Means you are committing something which a standard and reasonable person of your faculty would, you are committing something which a standard and reasonable person would not have done, and you are doing something which should have been like either commission or omission. So if these two things are there, it amounts to negligence. Now, for defining a person as negligent, there are 4 Ds. One is duty recognized by the law. It means whatever the act a doctor is doing, that should be a duty of the doctor within the scope of his duty. Another is dereliction of duty. The same duty, it has been established beyond doubt because the burden of proof is on the plaintiff. If somebody is accusing me as a Dr. Tiwari negligence hai, so it is his duty to prove the burden of proof. So मेरे अगेंस्ट बर्डन प्रूफ पैदा करना उसका बर्डन है. So if he is able to prove that it was my duty to do that job and I have derelicated that duty, and because of that duty and the cause, duty and the damage caused to him has direct causal relationship, means whatever I have derelicated that has directly caused damage to that person, and damage or death is another definitely fourth factor which is important. So if all these 4 criteria are satisfied, then one can be said to be negligent. My this thing is moving, slide is moving very fast, so I'll just correct it before going ahead. Slide is moving fast, so just give me some time so that I can correct the same. Yeah. Now we will come to see what is the sonography, safety of the sonography itself. United States Food and Drug Administration has limited energy exposure. It has limited energy exposure from ultrasound to 94 milliwavelength per square centimeters. Means that much ultrasound wave, if somebody is giving to some person, it is acceptable. Now we are using very less sonography waves when we are doing sonography. This is basically we are doing diagnostic sonography. At certain places, the sonography is used for the therapeutic purpose also. So in that the waves are more, but there also in our field, like we are using for ultrasound therapy, focus ultrasound for therapy for fibroid, there also the wavelength is quite less than what has been recommended or what has been limited rather. ACOG in 2004 committee of ACOG, they opined and they have guidelines for diagnosing imaging during the pregnancy. They noted that there are no reports of adverse fetal effects of diagnostic ultrasound procedures, including Doppler imaging on the fetus. Now there is one more organization which is known as American Institute of Ultrasound in Medicine that has recommended ALARA principle, and they have said lowest possible ultrasound setting should be used to gain necessary information on the sonography. One more interesting information they have given, that 2D versus 3D machine. They have said that if you are using 3D machine, it is not advantageous over the 2D machine while diagnosing the anomaly. It has been found in their study. Now, what is the spectrum of negligence? How the negligence can occur during sonography? Forget about Cleft lip, forget about any kind of anomaly you are missing on the sonography. They fall under only two categories. One is perceptual errors, another is cognitive errors. Now, what is perceptual errors? Perceptual error is nothing but missing a diagnosis. The anomaly is there, but it has been missed by the sonologist. If you miss the anomaly, you become a sinologist. It is as if you have done a sin, but it has been missed. It is there, you have missed it. Why this error can occur? This error can occur due to different causes. Either a suboptimal ability to perceive. It is said that eyes cannot see something which mind does not know. If I am unable to, if my mind is not fixed what I am supposed to see, then definitely I will miss the diagnosis. Another is overlooking. The third one is a difference in the human anatomy. Now, how to reduce perceptual errors? The same organization, they are given certain points how to you have to ponder such points in order to prevent the missing of perceptual errors. Proper positioning and exposure of the area under examination. Taking proper history. Many times patient comes up with a history. Patient herself tells in our field कि मुझे गांठ हो गई थी बच्चेदानी में, इसको सोनोग्राफी किया था, उस पर समझा था. तो उस पर we come to know partially that either it is adenomyosis or fibroid. So taking proper history and asking previous records plays an important role, wherein this I gave the example of gynec, but even for the obstetric sonography they give certain history कि पहले बच्चे को कुछ ये हुआ था, वेन हुआ था, इसको ऐसे abortion करना पड़ा. Such kind of history, or they have the old reports. The review report on the review, always review the report or take the second opinion. You can write whenever there is doubt. You can review your own report or you can go for the second opinion. Keeping various differential diagnosis of any disease in mind, and statistical probability should always be kept in mind while reporting. Means the rarest thing should not be reported in the first go. Always the common diagnosis should be kept in mind. Now, cognitive errors. Cognitive is interpretation of the visualized abnormalities in the wrong manner. For example, I have given the example of gynec again because it is easy to understand. Retroperitoneal tumor is mistaken as a tumor of abdominal organ. Means the anomaly is there. It is there, but you have been perceiving it differently and little bit deviation from the actual thing is there. So it is cognitive error. You are not totally missing, but you are confusing that with something else. Suppose there is a sacrococcygeal teratoma and you are missing and you are reporting it as abdominal. The position is not proper. Or some another bone structure, if it is lying on it, you are reporting as a bone tumor. So like that, there is a superimposing of the image. Because of that, you are not missing totally, but you are confusing that with some another error. Now we'll go to the case studies, which can show the gravity why Dr. Monica and the entire team, Dr. Supriya and entire team have kept this topic. There is one case which is Senthil Scan Center versus Sridharan, 2009. It's CPJ, Consumer Protection Forum case is there. In this, second and third sonography was done. Gynecologist did the sonography. Then gynecologist referred the patient for sonography, second and third sonography to sonologist. But on all the sonographies, the birth defect was missed. And after the baby was born, there was a stump below the elbow. Means one hand, right hand, they were not having the forearm. Only a stump was there above the below the elbow. So here the state and the central commission, obviously the patient went to the consumer forum. The district level fora, state and the central commission, they held that there is definite failure in diagnosing of the scan correctly, and the doctor was awarded compensation. But the doctor again approached to Supreme Court, where Supreme Court held that sonography is not a perfect depiction of the fetus scan results, and it can go sometimes if there can be a confusion, and the doctor was acquitted. So in the case studies, in the same study, the court said that it is often difficult to examine some fetal areas for several reasons. There is ample scope for difference of opinion. One man is not negligent merely because his conclusion differs from that of another person. The same thing which is known as Bolam's rule in the parlance of medical legal field. Bolam's rule में थोड़ा deviate होता हूँ. I'll tell you what is Bolam's rule. Bolam's rule is Bolam was a patient actually. He was suffering from some psychiatric illness for which long back on one hospital in UK, he was given ECT, electroconvulsive therapy. And in that during that therapy, that time there were two opinions. Some doctors used to give the sedation by giving Pethidine and those drugs for that time. And some doctors, they didn't used to give the sedation. So here the sedation was not given. So the Bolam, he moved rampantly. And because of that, there was a trochanteric fracture. The Bolam was cured of his psychiatric illness, but trochanteric fracture रह गया. तो उसके लिए उसने क्या किया, हॉस्पिटल मैनेजमेंट और साइकेट्रिस्ट पे केस किया. वो केस में बोलाम्स रूल एस्टैब्लिश किया, लैंडमार्क जजमेंट वाज गिवन बाय द यूके कोर्ट, एंड दे सेड दैट a doctor cannot be expected to be the highest level of competence. If two schools of thoughts are there, and if a doctor is following one of the established school of thought, he cannot be held negligent. So here the same principle is applied. One man is not negligent merely because his conclusion differs from that of another professional man. Another thing court said was there is no evidence to show that failure to detect deformity was due to the negligence on the part of the doctor. Another case study, important case study we see here. The अभी जो पहले case study देखा उसमें डॉक्टर के फेवर में रिजल्ट आया. So many studies are there, लेकिन यहाँ पे मैंने सिर्फ सोनोग्राफी रिलेटेड लिया है, बिकॉज यहाँ पे तो सोनोग्राफी रिलेटेड केसेस भी लैंडमार्क नहीं होते. इवन मिसिंग अनोमलीज ऑन द एक्सरे, सीटी स्कैन, MRI of different field also, they can be held as a landmark cases for our as a precedent for our judgment. हमारे judgment के लिए वो केस भी एक precedent करके जज ले सकता है. Now one more case is Vinesh Hospital versus Mr. Anil Dutt and Anju Dutt. Mr. Indira Vyas here is a gynecologist. She advises sonography, routine anomalies, routine obstetric scan for fetal well-being. ऐसा लिख के she refers to radiologist. Radiologist performed scans on 2 occasions. Gynec ने radiology को भेजा, gynec ने anomaly scan नहीं लिखा because the patient had approached to the gynecologist late. तो उन्होंने सिर्फ routine observation scan लिखा. And they once wrote that now यहाँ पे radiologist ने 2 बार scan किया, दोनों बार normal लिखा, और एक बार उन्होंने लिखा कि there specifically he wrote कि there is no trunk, limb, spine anomaly noted. ऐसा statement उन्होंने report में लिखा. The baby was born with missing left hand and underdeveloped lungs. Now here a case was filed. And here the case was filed for 1.5 crore compensation. The court went to the highest supreme forum of our apex court, and here 1.5 के बजाय 15 lakhs compensation was awarded by National Consumer Distress Redressal Commission, means highest court of consumer redressal. 15 लाख उन्होंने compensation डॉक्टर को देने बोला. Now यहाँ पे court दो ordered compensation. Court was observed certain things. Anju Datta versus Vinesh Hospitals, Dr. Soni and Dr. Salman. यहाँ पे कोर्ट ने anomaly scan लिखा नहीं था, ऐसा रेडियोलॉजिस्ट का बोलना था. रेडियोलॉजिस्ट बोला anomaly scan was not written, so I did only routine scan. So in answer to that, court said that if some pathologist, court gave the example of pathologist. कोई pathologist है, उसके पास CBC के लिए सैंपल भेजा और वो सैंपल देखते समय उसको मलेरिया पैरासाइट दिखा, तो is it possible that he will not report the malaria parasite? वो बोलेगा patient was referred only for the CBC, so malaria parasite, doing malaria parasite is not my duty. So that way pathologist cannot tell. Similarly, if a person has been referred for sonography to a radiologist for just routine scan, it doesn't mean that if some anomaly is detected, the radiologist should not report it. On that ground, the compensation was ordered. There are many other grounds also. The obstetrical USG, in that the court said certain things which I would definitely like to quote because they are important for our practice. Here, obstetrical USG is not a full group in detecting anomalies. The sensitivity of the USG depends upon various factors. The court said like quality of equipment, type of congenital anomaly, gestational age at the time of scan. It has all been written. This all has been written in the judgment delivered. Maternal body habitus, amniotic fluid content, etc. Now, another cases are also there, which is the KM Tiwari versus Dr. Bandopadhyay. Here, twin pregnancy was missed, and I know the Mr. Tiwari, he went to consumer fora, and doctor was ordered the compensation. Now, another case is of B. Krishna Rao versus Nikhil Hospital. Here the court said, see, this case is not related to the imaging, but here one important thing court said. The previous slide I spoke about expert opinion. So expert opinion is always sought whenever certain negligence occurs. The negligence, whenever it goes especially to a police or a consumer, they take opinion from the expert from the same field. So if the expert gives opinion, adverse opinion or whatever, that is regarded with grace by the court. But in this case, the court said that many times experts are doctors and they are not totally, they are trying to shield other doctors. So expert opinion is not mandatory for the court to accept. Even if expert opinion दिया है कि डॉक्टर सही है तो भी कोर्ट उसके अगेंस्ट रिजल्ट दे सकता है. इस तरीके का जजमेंट बी कृष्णा वर्सेस निखिल हॉस्पिटल में कोर्ट हैज सेड. Now there are certain ways which one can get sued for the ultrasound for the purpose of missing anomalies. Now what are those 19 possible ways? Now basically one important is missing sonography finding. Basically you are doing sonography casually and missing findings. Misinterpretation of sonography findings. Either you are missing or misinterpreting. Either is a perceptual or cognitive. Failure to compare findings with the previous ultrasound. Means somebody else or you have done previous ultrasound but you are not comparing with that. So that can also lead to the medical legal problems. Failure to properly communicate the sonography report to the patient or referring physician. Failure to personally examine the patient or take proper history. Incorrect sonographic approach for a specific condition. Suppose it is a abdominal obese patient and a small ovarian tumor or small ectopic, you are doing only abdominal sonography, even if the patient is like not reluctant to go for TBS, then it is you are not giving a proper approach for sonography. Incomplete examination, slip and fall injuries. So this actually ultrasound as well as other X-ray also they are given. So slip and fall injuries they are given. उसमें बहुत सारे even if the rightly reported, there are difference of opinions. So many times the anomalies get missed. Failure to obtain informed consent, complications of ultrasound such as induced vaginal bleeding, abortion, etc. If such things have not been explained to the patient, if TBS is done infertility, conception, and later she bleeds, and she can also, the bleeding might be incidental, it might not be related to the sonography, but she can file a case against you. Equipment complications such as electric shocks, failure to recommend additional sonography or radiological studies, biopsy, etc. Inclusion of sonologist in shotgun suits means many other shotgun suits basically are very sensitive in the UK. This is a finding from UK and USA. So there in shotgun suit invariably the radiologist is included. So that is also one of the important indications for reasons for getting sued. Loss of films, inadequate filling systems, misplacement of fields and reports, abuse of patient by sonologists like mental or sexual trauma, etc. Now 10 and 11 I have not quoted. Complications from puncture techniques, like if you are doing amniocentesis, complication, that can be one of the reasons for your suit. Now there is something known as picture archiving communication system and loss of records. Picture archiving or communication system, PSC system, it is not archiving system. It is not followed much by gynecologists, but radiologists are following it. उसमें क्या होता है, रेडियोलॉजिस्ट किधर एक सेंटर पे काम करता है और 4-5 सेंटर के सोनोग्राफी रिपोर्ट देता है. जैसे हमारा स्कैन कोई पालघर में रन कर रहा है और रिपोर्ट इज बीइंग गिवन फ्रॉम मुंबई. So they have different system wherein the reports are sent to him at the multiple level. The reports roam. आज मैं MRI कर रहा हूँ, MRI सोनोग्राफी कर रहा हूँ, the report will go to one radiologist. वो देखेगा उसको. He will take second opinion from second. So there are multiple levels, multiple stops before the picture actually goes to the final हायरार्की वाइज जो सुपीरियर और एक्सपीरियंस पर्सन है उसके पास जाने तक समय लगता है और बहुत जगह को फिल्टर हो जाता है. उस समय में वो डाटा लॉस्ट हो सकता है. If the record is lost at such time, it is considered as spoliation in terms of legal parlance. That means the court interprets that since the records were unfavorable to the defendant, he has destroyed the same. गलती से भी भूल गया तो कोर्ट उसको ऐसे बोलेगा कि इसके लिए फेवरेबल नहीं था, इसलिए जानबूझ के उसने डिस्ट्रॉय कर दिया. Sonologists using PSE should implement quality control mechanisms. All performed reports are successfully transmitted to the POC network or not should be properly monitored. There should be mechanism to identify and address uninterpreted PSE examinations in case of all reports are lost before interpretation, and one should request the referring doctor to repeat and resend the same. By chance को miss हो गया तो we can request the referring doctor to फिर से भेजने के. So all these things should be followed. Now, signing a colleague's report. Many times it is like uncommon for the gynecs because हम लोग खुद ही करके खुद ही sign करते हैं. But many times in many institutes, बड़े institutes है, कोई आधा लिख के गया, फिर उसको complete किया, report और sign किया. It is possible. So, to avoid the need for signing other sonologist report, it is advisable to create a folder or of preliminary report. एक temporary report का folder बनाइए, उसमें let the referring sonologist review करो और leisure time he can sign it. Means complete the report, keep in a folder, he will read and sign, he or she. Sign a colleague report only under circumstances whether the delay in the final signing by him would be clearly seen as unforeseeable. The legal risk, however, persists. Means बहुत ही urgent है और उसका diagnosis देना is urgent. Then in that case, you can sign the colleague's report after appropriately communicating with him and getting satisfied by yourself. Carefully proofreading and review should be done before signing. Disclosure to proxy signing should be there in report if reports are signed by 2 or more radiologist or gynecologist. Now, what is vicarious liability? Vicarious or vicarious liability is respondent superiors. Means somebody has been employed by me to perform duties on my behalf, and there is some negligence on his part. Then it is perceived to be negligence on my part. Within his scope of employment, if the employee does something, employee को रखा है सोनोग्राफी करने के लिए मैंने, या तो कुछ सोनोग्राफी में हेल्प करने के लिए कर रखा है और उसमें कुछ एरर हो गया, तो दैट इज कंसिडर्ड एज एरर ऑफ मी इफ इट लाइज विद इन द स्कोप ऑफ हिज ड्यूटी. उसका कुछ अलग प्रॉब्लम है, he goes and beats somebody or some molest somebody, that is not none of my job because it is not within the scope of employment. Why? Face it per alium per se, that is the one who acts through another, acts in his own interest, and it is parallel to the vicarious liability. So such liabilities can also occur while reporting as well as writing and giving the reports also. Now there are certain newspaper cuttings which I have taken. Doctor can't be held negligent for missing an anomaly caused due to genetical and environmental factors. Was one judgment given, and as well as one study was done on that. Now there can, in this case, court has given certain irrefutable facts. The patient conceived after 4 months of an abortion. She consulted obstetricians. Here is a case study of that judgment, that case where the judgment was given. Time है ना अभी? Dr. Monica, shall I speak for some 2-3 minutes?
Yes, yes, sir. Yes, sir.
Yes.
The patient conceived for 4 months of abortion, and she consulted obstetrician. The doctor confirmed pregnancy. USG already abort ho gaya tha patient, and she consulted obstetricians. The doctor confirmed pregnancy. USG conducted at regular intervals, reported the fetus to be normal. The doctor noticed the development of placenta previa of grade 2. मतलब जब वो abort होने से पहले डॉक्टर ने ऐसे लिखा था कि placenta previa है. Then doctor at 30th second day of 30th week, means detail में लिखा है around 30 weeks, the doctor thought that placenta previa है, तो he referred to some higher center. There the repeat sonography was done, वहाँ पे placenta previa नहीं मिला, and nothing was there. I mean, only placenta previa, not ऐसा finding है, and fetus there also was normal. Eventually, the patient gave birth to baby with absent left forearm here also, and the patient sued the obstetrician. It was alleged that despite conducting several scans, the doctor intentionally concealed the fact that the fetal congenital anomaly was there. Here the allegation was doctor को पता था, इतने डॉक्टर ने 2, 3, 4 स्कैन किए, 3 डॉक्टर इन्वॉल्व थे, उनको पता था, फिर भी उन्होंने अनोमली बताई नहीं और प्लेसेंटा प्रीविया था भी नहीं तो उन्होंने बोला है. इस तरीके का एलिगेशन उन्होंने डॉक्टर ने किया. डॉक्टर्स प्ली वाज कि डॉक्टर पॉइंटेड आउट दैट हाई रिस्क प्रेगनेंसी था, इसलिए डॉक्टर पेशेंट वाज ट्रांसफर्ड. ड्यूरिंग 14th week there was placenta previa, and the patient accordingly was informed regarding the placenta previa. Treatment was advised. Thereafter, all reports including physical examinations are normal. The doctor further pointed out that EVG performed during 30th week of pregnancy revealed grade 3 placenta previa, and accordingly the patient was transferred. But later on, patient went after 20 days to the another hospital, wherein there is a possibility that the placenta might have migrated. Now, court क्या बोलता है इस केस में? Court said, after careful pursuit of medical literature and medical records, the State Consumer Commission accepted obstetrician's defense. उसने accept किया कि obstetrician is right. The court observed that sonography may not reveal anomalies unless they are predominant anomalies, and accordingly concluded that giving birth to an anomaly, with anomaly will not amount to medical negligence because the said anomaly was caused only due to genetical and environmental factors. The court further observed that placenta previa may go up, means may disappear at later stages of pregnancy. The court accepted it and rejected the patient's allegation that she was referred to second hospital for false reasons or intentionally her anomaly was hidden by the doctors. Now, to conclude all these things, the performance of obstetric sonography is medico-legally high-risk activity. One has to upgrade the instrument. Both are important. Arch be important, archer be important. So both should be upgraded. Means our own skills as well as the sonography machine should be acknowledged. It should be periodically updated. We should comply with the PCBT, PNDT, and MTP Act strictly to minimize the medical legal risk. And there are ACOG, AIUM guidelines, area guidelines are there on the website. So such guidelines should be time to time. We should evaluate and we should try to follow the same. Thank you very much.
Excellent
Thank
talk,
you,
Dr.
sir.
Aditya Tiwari.
Thank you,
Thank you,
Dr.
sir.
Tiwari.
Thank you.
Geeta ma'am.
Sir, I have one question for
yes,
you.
sir.
Thank you so much.
Yeah.
I have one
also have one
question for
question for
Dr.
Dr.
Tiwari.
Yes, ma'am.
Sir, actually, it is not pertaining to the anomaly. Are we obliged to give the
Because a very
ultrasound
interesting
photographs
observations
to
such type
the
of
patient? Because in medical colleges and hospitals, we just give a report. We don't give a printout. One
Ma'am,
of
there
our
is a
patient.
judgment
Thank
in
you.
that also. In the judgment, court has said the plate should be given to the patient.
The court has said plate should be
Court has
given.
said in one judgment. So it
Yeah.
is mandatory
Yeah,
to
yeah.
give the reports. Even the PCPNDT Act, it says the report should be plate should be preserved. There is a different column for that in the Act also.
Dr.
So ideally, the plate
Dr.
should be given
Tiwari,
because they can take second opinion.
Dr. Tiwari, I have one question for you. Are you
Yes,
listening
sir.
to me?
Good evening,
How
sir.
are you?
First of all,
Yeah,
I was
good
missing
evening.
you.
Yeah. One, so I came. I was so busy. When the patient we are showing doing ultrasound, that time patients relative insist that they should come and they want to see, and then they want to do videography. Is it allowed, and how much it is allowed, or whether it is not allowed, and what are the
Obstetric
implications?
sonography, videography, PCPNDT is silent on it, but videography is not permitted because the patient can use the same video. It has been said several times that the same video patient can use and go to some another sonologist, and it can be misused for sex determination. So videography is not allowed, but plate should be given.
Plate can be given, but is it allowed that it can come and see along with that? There is no
They can see,
obstruction
yeah,
for that.
definitely.
They can see. Yeah, your presentation was excellent. So many new things we got to learn. It was an excellent presentation by Rajendra.
Thank you, sir.
Thank you. Very much.
Thank you, Rajendra
Anybody
sir, and
want-
thank you, Geeta ma'am. Over to you, Ujjwala ma'am, for your comments.
Just 1 second. Yeah, I will. Just there was a difficulty, sir. Hello. Am I?
Ma'am, you are audible.
Yeah, you are audible.
I had one difficulty.
Voice is less. Your voice is low. Dr. Ujjwala, your voice is low.
Am I audible?
Yeah, but the voice is low.
Am I audible, sir?
Yeah, now you are audible. No, again voice
Hello.
is low.
Hello.
Please
Yeah.
tell. Please tell.
Yes, please speak.
Yeah. Sir, there was a case with me only. Somebody sent a patient to sonologist. Patient delivered there at the time of sonography. The sonography center was nearby me. So he called me, I sent my staff over there, completed delivery. And then after, the person whose wife delivered, he started allegations with me only. About disputes about the birth certificate and all. So what is the way out for it?
Actually, birth intimation is the duty of the head of the person where the patient has delivered. If the patient is delivered in a, for example, say railway station, the station master of railway will inform. If it is delivered in hospital, hospital will inform. So birth registration act says that wherever the patient is delivered, they are supposed to intimate to the authorities. So from there they get the birth certificate. ऐसा certificate तो हम देते नहीं, हम लोग intimate करते हैं. But for patients' convenience, many a times home delivery करके हम लोग उसको accept कर लेते हैं outside delivery, and we are giving the certificates for the ease of the patients. Otherwise, information, intimation can be given by any person, even a non-medical person also can give intimation to the appropriate civic authorities. Maybe Gram Panchayat rahega, ya Nagar Parishad, Panchayat Council, whichever civic authority is there. Any person can give the intimation. ऐसा हम जो दे रहे हैं वो intimation ही है, certificate नहीं है. Certificate authority देती है.
Yes, means intimation sonology should have been given that.
Ideally, legally speaking, sonologist should give because uske under हुआ. He was the head of that institute. But many times we accept the patient as outside delivery and we intimate it. जैसे मेडिकल कॉलेज में रिक्शा डिलीवरी होती है तो उसको ले लेते हैं, बाद में उसका इंटीमेशन मेडिकल कॉलेज ही करता है. Legally speaking, a person जहाँ डिलीवर होती है, it is the responsibility of the head of that institute.
This happens many times. Even at our hospital, patient comes delivered in rickshaw, so we take it our from our side and
we take it
intimate
as our patient and we mention it is rickshaw delivery and we just intimate to the authorities.
But here
So
is
that is the way of-
sonology institution that another part is involved. So just I get
Ideally
it.
sonologists,
Thank
but
you.
they are not equipped with everything. So normally we are accepting the patient and doing that job on their part.
Yeah. Okay. Means intimation. You also could have, or even anybody.
He can also give, if he wants, he can intimate regarding the birth to the authorities.
Thank you, sir. Thank you.
Thank you, Ujjwala ma'am. Thank you, Chavan sir, and thank you, Geeta ma'am, for chairing this session.
Thank you, Rajendra.
Thank you, sir, for
Thank you. Thank you, Dr.
Accepting our
Monica and the
invitation
entire team.
presenting such an elaborate talk on such an important topic.
Yes.
Thank
Thank
you so much.
Thank you.
Yeah.
Thank you,
Yes,
madam, for involving us.
Yeah,
Thank you,
thank you,
ma'am.
Monica, for giving this chance to be over here. Thank you so much.
Thank you, ma'am.
It was a great chance for us. Thank you.
Thank you, ma'am. Okay, we can now move forward for the academic session part 2, which is by the Smile Train. Harsha, can we have the slides, please? Yeah. Our chairpersons for the next session are Dr. Shamita Birbole, madam. She is a fertility consultant with an IVF fellowship. She is also practicing laparoscopy and hysteroscopy. She has a diploma in anesthesia also, and she's the director of Guru Kripa Multi-Speciality Hospital. She is the secretary of Sindhudurg OBGY Society. We welcome you, ma'am, for chairing this session. Our next chairperson for today, Dr. Datta sir. He has worked under pioneers like Dr. Kamal Deshmukh madam and Dr. Vasant Patwardhan sir. She is also trained in laparoscopic surgeries from Professor Kurzem from Germany. He is the General Secretary of Grand Medical College Student Association and the Secretary IMA Thane branch, the President of IMA Thane and the Secretary General of Thane OBGY Society. He has been the past member of Foxy MTP Committee also. Currently, he is the Vice President of Thane OBGY, President of the Thane OBGY Society. Sorry, sir. We welcome you, sir. Our next chairperson. The next slide, Harsha. Dr. Santosh Jaivar, sir. He has done his post-graduation from, say, GS Medical College. He is a practicing obstetrician and gynecologist in Navi Mumbai and Raigad. He is the Joint Director of Om Sai Multispeciality Hospital and the Vice President of Navi Mumbai OBGY Society. He is a passionate trekker and a marathon runner. We welcome you, sir, to chair this session. I request Dr. Shamita madam to introduce our speaker for today. Ma'am, you need to unmute yourself.
Yeah. So
Yes, ma'am.
yeah.
The next speaker, Harsha, Savita ma'am, slide. Yeah.
Yeah, I'd like to welcome Dr. V.H. Savita ma'am. She has adjunct faculty at Sri Ramchandra Faculty at Audiology and Speech Language Pathology, Professor and Head of Department at SRM Medical College, Chennai. Masters from All India Institute of Speech and Hearing, Mysore, 2003. Also, she is a master trainer for Cleft speech in India. And her work of interest is focused on cleft lip and palate. She likes to give the speech services. She's a coordinator of Sri Ramchandra University Smile Train Speech Training Initiative and recipient of the Braithwaite Oration by the Indian Society of Cleft Lip and Palate Related Craniofacial Anomalies. She has many publications and presentation done. She's authorized 14 publications and 3 book chapters, and deliver numerous presentation at regional, national, and international scientific forum. From our side, we like to welcome V.H. Savita ma'am to enlighten us on this Smiling Train project. And definitely, we look forward to involve ourselves also in this project. Thank you, ma'am. Welcome to the lectures. Thank you.
Thank you very much, Dr. Shamita, for the wonderful introduction. And a very good evening to all the participants of this program here today. Just give me a moment to just share my screen. Yeah, is my screen visible to all of you?
Yes, ma'am.
Yeah, thank you very much for inviting me to make this presentation on behalf of Smile Train, talking about a very major issue that we often encounter among children with cleft lip and palate, that is problems in their speech production. So cleft lip and palate is one of the most common anomalies. It's a very common birth defect. Like we almost have one child with cleft being born every 3 minutes in our country. So this is a problem that affects multiple aspects of a child's development, and it impacts the quality of living eventually. So among the various gamut of problems that we see in cleft lip and palate, one of the common ones that we notice is the speech problem. So in this presentation, I'm going to kind of quickly take you through how speech is produced in a typical situation, and why is it that cleft lip and palate impacts speech and language development children when it is seen, and what exactly happens even before children start speaking, because there are some factors that are happening even before they start speaking that has an impact on their later speech and language development. So what happens before speech emerges, and once speech emerges, what are the cleft speech characteristics? And the last part is the most important part of the presentation, where we will be talking about what is it that we need to counsel parents. This is one section where I think there will be a lot of take-home messages for the participants out here, because you all will be seeing these babies at a very, very young age. So diving into the presentation, the first part is how is speech produced? So when we're talking of speech production, there are two major factors that are involved here. One is the structural factors, or what we call as the physical factors. So if you look into the structures per se, we speak using the source of the expiratory air. So the respiratory system is what forms the source for all of us to be able to speak. And the expiratory air gets into our laryngeal system. And from the laryngeal system, it comes up into the articulatory and resonatory system. So I've highlighted the articulatory and the resonatory system here in yellow, and this is where the problem occurs for those with cleft lip and palate. So if the structural issues are one aspect that contributes to problems in producing speech, the other aspect is learning factors. Speech is a learned behavior, and very often we learn to speak in a particular manner, and as babies who are born with cleft lip and palate, they do produce sounds at a very early stage itself. So when they are learning to produce these sounds with the presence of a cleft, they start using certain maladaptations, or they start speaking in a manner to compensate for that presence of cleft. Now, this learned behavior, they continue to produce even after the cleft is repaired by around 10 months to 1 year of age. Normally, a cleft of the palate is repaired surgically by anywhere between 10 months to 12 months in an ideal scenario. And what happens is, because they were producing speech with errors before the palate was repaired, they continue to produce the speech with errors even after the palate is repaired. So the learned behavior plays a major factor here. So when we're talking of cleft speech, it's always a balance between the structure and the learned behavior. While the structural aspects are generally corrected by the medical professional who's involved, the surgeon takes care of dealing with the structural abnormalities there. Speech language pathologist comes into picture in taking care of the learnt maladaptations. So we need to keep in mind that for someone to speak well, we need both these factors to be taken care of, and both of these have to be addressed. So why is speech and language affected in cleft lip and palate? So I've already touched upon this in my previous slide. So one is the abnormal neuromotor patterns, which gets established when a child is producing speech sounds at a very young age. Children generally start producing speech sound. It might even be nonsense speech sounds that they produce or non-meaningful speech sounds that they produce, but they start producing the speech sounds as early as 6 months onwards. And when we're talking of a child born with cleft lip and palate, at the age of 6 months, the cleft of the palate is still there. It is not corrected as early as 6 months. So because the child is having this cleft at that age, the sounds that they produce become abnormal. If typically developing children produce more sounds like pa, pa, pa or g, 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 children with cleft produce more sounds like which are sounds that they are producing from the level of the throat. So these abnormal productions result in abnormal neuromotor patterns which get registered and persists even after the cleft is repaired. Cleft lip and palate results in a physical defect itself. We know there is a cleft that is there. The roof of the mouth or the palate is not present. So because of that, there is a physical defect, and that by itself directly contributes to problems in speech production. The other thing which is a problem which can be tackled if we counsel parents appropriately is this problem of altered mother-child interaction. Now, having a baby with a cleft sometimes is a big shock to a mother because they may not be aware of it in the prenatal stages itself. And when the child is born with a cleft lip and palate, there is a lot of psychological feelings and emotions that the family is going through, that the mother is going through. They are trying to cope with this particular condition, trying to gain knowledge about this condition, and trying to look at different means through which they can handle the child born with this condition. So as a result of all of this, sometimes what happens is the normal mother-child interaction that we see, or the normal caretaker-child interaction that we see, becomes affected in children with cleft lip and palate. There can be altered mother-child interaction, wherein there is less interaction happening between the child and the caretaker. And sometimes there is also very less demand placed on the child to communicate, leading to altered communication patterns in the course of development. Children with cleft lip and palate are also prone to have fluctuating hearing losses because the cleft of the palate can sometimes affect the functioning of the eustachian tube, resulting in middle ear problems and hearing loss. And this can also contribute to speech problems that we see in children with cleft lip and palate. So what is the earliest time at which we see problems in children with cleft lip and palate? Children with cleft lip and palate have problems as young as 6 months to 10 months. At around that age itself, we see some problems that emerge in their speech. The kind of speech sounds that children produce, what we call as babble, young children just babble, wherein they do not say anything meaningful, but just keep making sounds while they are playing. Problems in cleft lip and palate, children born with cleft lip and palate can be seen as young as 6 months to 10 months during this period of babbling itself. It can start from there. And as parents, when can they notice the earliest signs? It is during the period of onset of the first meaningful word. If children born without cleft lip and palate generally produce their first meaningful word by their first birthday. That is, by around 12 months, we expect them to have produced their first meaningful word. There is almost a delay of more than 6 months in children with cleft to begin producing their first meaningful word. So this is probably one of the earliest things that parents sometimes notice and say that my child has still not produced the first meaningful word. And this delay can go on as much as 6 to 10 months delay can be noticed here. So we do not see the early word or the meaningful word production till around the age of 18 months or so in children born with cleft lip and palate. The delay in their language development can be seen both in terms of receptive language and expressive language, with greater delays in expressive language. So what you see here is the language levels or the language age of children at the age of 32 months. So when the typically developing children at 32 months have language ages of 31 months or 30 months, children born with cleft lip and palate have it only in their 20s here. There is a greater delay in expressive language, that is their output is more delayed than their receptive language, that is their ability to understand language. So children with cleft might be able to understand what you say. They can execute commands, do actions that you're asking them to do and all of that. But when they have to express, there can be a delay that we notice, and the delay continues to exist till the age of 32 months at least. That's what we have in the literature from our population. So which means when a child is ready to go to preschool, this child is still having a language delay that we are dealing with. So this is one aspect of the problems that we see with regards to speech and language in children with cleft lip and palate. But once they have started producing meaningful words, once they have started getting the vocabulary and kind of, though there is a delay, they slowly start using words and sentences to communicate verbally. At that time, there is a whole gamut of speech problems that can emerge in children with cleft lip and palate. Now, what are these problems that we commonly notice, and which of these are sometimes to be used as red flags? The first most common error production that we see is atypical consonant production. Children with cleft do not have much difficulty in saying the vowel sounds. Vowel sounds are easy. All are a, e, a, o. These are very easy for them to produce because there is not much manipulation that we do in the cavity to produce these sounds. But the moment we talk of consonants, that is where there is a lot of air pressure modulation that happens within the oral cavity. And that is where we can find atypical productions. So the atypical consonant production is generally revolving around those sounds that has the need for complex airflow modifications in the oral cavity. So if you look at it now, this is just, I've just tried to explain to you that in a normal case, we produce speech sounds at different places in the oral cavity. So like, for example, when I'm saying the sound pa, I'm using my lips to produce the speech sounds. When I'm saying the, I'm using my tongue tip against the teeth to produce the speech sound. When I'm saying ka, I'm using the back of my tongue to produce a speech sound. So there are different places in the oral cavity in which we produce speech sound. And we also produce speech sounds in differing manner. So for example, when I say the the sound, I'm completely stopping the air and then suddenly releasing it. But on the other hand, when I say the S sound, it goes as I'm producing it by continuously prolonging the air. So the manner in which we modify the air, am I completely stopping and releasing it? Am I making a small constriction and continuously releasing it? Am I making a large opening and just producing the speech sound? Am I bringing sound through the nose? Am I making sound through the mouth? These are what we call as different manners of articulation. So in the sounds that involves the stops, the fricatives, and the affricates, those are the most challenging ones for those with cleft lip and palate because they involve maximum air pressure modification. So just to give you an example, the sounds that are difficult for children with cleft are the pa series in Hindi, that is the pa, pa, ba, bha, the ta series, the tha, tha, da, dha, the ta series, ta, tha, da, da, the ka series, the ka, kha, ga, ga, and the sa series, that is a sa, sha, sa, ha. These are the difficult ones. The last ones in each of these series, that is the ma, na, ng. Those are all nasal sounds which are normally produced by air coming through the nose and not through the mouth. And these are not difficult for children with cleft to produce. So children with cleft have greater difficulty in producing the p, the, k, ch, s, and their related counterparts there. Now, when they have difficulty in producing this, there can be two kinds of changes that we notice. One, what can happen is when a learned misbehavior or a learned maladaptive pattern is affecting, what happens normally is they produce the sound in a correct manner, but they change the place where they're supposed to produce it. Like, for example, if the ta is a sound that's produced using the tongue tip, instead of using the tongue tip, they can use the back and they can produce a ka, ka. Or sometimes it can go as back and they can produce it from the throat level. So ta can become a ah. They will stop the air at the level of the throat and release it. Or a ka can become a ah, which is a sudden constriction that they are doing at the level of the throat. So this is where they are altering the place where a sound is being produced. On the other hand, they can sometimes change the manner in which the sound is being produced. So what do they normally do? Instead of releasing the air through the mouth, they can release it through the nose, resulting in a nasal sound. So if you have a sentence, for example, like Pappu Papita Pakdo, instead of it coming as Pappu Papita Pakdo, it can get produced as Mammu Mamita Magmo, wherein everything is coming from the nose rather than it coming from the mouth. So this is another altered production that you can see. So either they change the place where a sound is being produced, or they change the manner in which the sound is produced. Normally, if there are residual structural deficits, like for example, the cleft has been repaired, but even after the cleft is repaired, sometimes there can be a breakdown in the cleft wherein it results in a fistula. Or sometimes the cleft is repaired, but there can be another condition called velopharyngeal dysfunction, wherein the back portion of the mouth is not closing appropriately for speaking. So I'm going to quickly take you back to this picture that we discussed. Now, this part, the posterior part of the oral cavity here, has an important thing that's called the velopharyngeal port. Now, the expiratory air which is coming out has two channels through which it can come. It can either come through the oral cavity or it can come out through the nasal cavity. Now, what determines whether this is going to come through the oral cavity or the nasal cavity is this velopharyngeal port. If the soft palate, or what we call the velum, will go and approximate against the posterior pharyngeal wall and close off this opening, then air comes through the mouth. But in children with cleft lip and palate, there can be a coexisting condition that's called a velopharyngeal dysfunction, wherein despite this palate being repaired, it may not go and close against the posterior pharyngeal wall appropriately. So if there is an opening there, air takes the path of least resistance and comes through the nasal cavity, resulting in nasal productions at times. So that is a condition that's called as velopharyngeal dysfunction. So when we have abnormalities like a fistula or a velopharyngeal dysfunction, then what happens is the manner of producing speech sounds can get altered. But when I see a lot of problems with just the placement of the speech sounds, then it is an indication that that is a child who requires more speech therapy rather than any further structural correction. So we classify them as obligatory errors or compensatory errors. By listening to the speech and by delineating the speech characteristic that is affected there, we will be able to do it. Now, it's very important for us to be able to differentiate between these two, because the moment we have a child showing obligatory error, it means this child needs further structural correction there. It might be the fistula that needs correction. It might be the velopharyngeal port that needs correction. There is a need for a secondary correction that is there the moment it is an obligatory error. But if there is a compensatory error, that is an error where the placement is what is getting altered, then this that patient will directly require a speech therapy. And the earlier we start that speech therapy, the better will be the results that we can notice. So this is with regards to the articulatory errors that we can notice. Now, sometimes along with the production of articulatory errors, children can also produce this phenomenon called nasal air emission. Now, when we speak, as I told you, for majority of the sounds, that is the p, t, t, k, or the b, the, d, g, s, for all of these, we expect sounds to come, the air to come only through the oral cavity. Now, for these oral pressure sounds, children with cleft lip and palate can sometimes produce it with an air coming through the nose. So, to give you an example, a syllable papa can sound as pa, 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 with the air escaping from the nose along with the production of the speech sound. So such instances are an indication that there is a leak of air going somewhere in the system. So when they are trying to build the intraoral pressure, it is leaking and escaping from the nasal cavity. So we can have sometimes an inaudible emission or an audible emission. What I produced now is an audible emission. Sometimes it's not so obviously audible, but the moment I keep a dental mirror under the nose while the person is speaking, there will be fogging for the production of oral sounds, indicating that there is air escape from the nose. So some of the causes for nasal air emission can again be fistula or velopharyngeal dysfunction, the conditions that I explained earlier to you. The next aspect that we talk about when we are talking of speech problems is the resonance. Now, what do we mean by resonance? All of us have a normal quality of speech. We have a particular quality. So there is something that distinguishes my voice from somebody else's voice. And it's very easy to make out those differences for us. Now, why am I having this particular quality? This is dependent on the size and the shape of my oral, nasal, and the pharyngeal cavities. The moment we bring about some changes in these cavities, the quality can alter. So, and as I already told you, this is the velopharyngeal port, which plays a very major role in determining the shape of the cavity. So when the velum is going and closing against the posterior pharyngeal wall, the air can escape completely through the oral cavity. And this is the size and shape of the cavity that we're dealing with. But the moment this is open, then what happens is the air can come out through both your nasal and the oral cavity, and the shape of the cavity is completely altered there. It becomes a two-edged cavity, and the volume is also going to differ. So when the size and shape of the cavity is getting altered, the resonance or the quality of the speech output can also get altered. So one of the important structure that determines what is the quality of speech that we have, or what is the quality of voice that we all produce, is this velopharyngeal port. And very often, almost 25% of those born with cleft lip and palate, even after the palate is repaired, can have velopharyngeal dysfunction, wherein this velopharyngeal port might not go and close against the posterior pharyngeal wall. Now, this is an important thing that we have to identify. And how do we identify this? Is looking for the sound production again. We assess for the oral sounds, the p, k, t, th, s, ch, all those sounds, and we see whether there is any nasality that we perceive when these sounds are produced. So if a sentence like Pappu Papita Pakdo, this is a sentence that we speech pathologists commonly use in Hindi for assessing for the production of the p sound. So Pappu Papita Pakdo can get produced with a hypernasal resonance, that is an oral sound can have an increased nasal resonance and can sound as it is coming through the nose. It is an increased hypernasal resonance that we can produce, that we can perceive because of the velopharyngeal port not approximating against the posterior pharyngeal wall. So such escapes can be perceived at times, and we hear what we call as a hypernasal resonance, which is a very common signature characteristic that we see in individuals with cleft lip and palate. the oral sounds, the vowels, and the oral consonants are perceived with an excessive nasal resonance. This can again happen because of fistula, because of velopharyngeal dysfunction, and sometimes if it is mislearning, if it is a learned behavior, then we will see that only certain sounds are hypernasal. So for example, we may have someone who's producing only the S with hypernasality. All other sounds might be fine. Now, those are again instances where we have to take them in for speech therapy. Sometimes, on the other hand, very rarely in cleft lip and palate, but can still be noticed, is a condition called as hyponasal resonance, wherein my nasal sound lose their nasal energy and they are sounding oral. So if there is any obstruction in the cavity, like for example, if they have a very large tonsils, if they have an enlarged tonsils, or if there is adenoid hypertrophy, or if there is any other obstruction in the nasal cavity, then what can happen is the nasal sound does not come out through the nasal cavity and can come through the oral, which we call as hyponasal resonance. Though not very common in children with cleft lip and palate, we can still find hyponasal resonance in some small percentage of children with cleft lip and palate when it is coexisting with any tonsil abnormality or an adenoid abnormality. Then we can notice them. When these two factors are present together, then we sometimes find a mixed resonance wherein the oral sounds can be perceived with increased nasal resonance, and the nasal sounds can get produced with reduced nasal resonance. So we may find mixed resonance also in some individuals with cleft lip and palate. So these are some of the resonance abnormalities that we can see in children with cleft lip and palate. So we can see affected consonant production. We can see presence of nasal air emission. We can see presence of resonance disorders. These are the three factors that we have discussed so far. Going forward, there can also be dysphonia or laryngeal related problems that we can notice in children with cleft lip and palate, again in a very small percentage of the population. Not all children with cleft lip and palate end up having dysphonia, but we can see in around 20 to 40% of population of children with cleft lip and palate difficulties in producing voice. Commonly what happens is there can be breathiness, there can be hoarseness. They may produce speech with low intensity, or sometimes they may use excessive glottal fry during production. So why is this happening? Now, this can also go back to this functioning of the velopharyngeal port. Now, what happens is when there is a velopharyngeal opening, when the port is not closing properly, we lose the air pressure at this level, at the level of velopharyngeal port. So in order to compensate for the loss of air pressure at the velopharyngeal port, children with cleft lip and palate unknowingly put additional pressure onto the laryngeal system. There is over-exertion of the laryngeal system to compensate for this loss of air pressure at the level of the velopharyngeal port. So this can sometimes result in overusage of the laryngeal system, leading to what we will call as a hyperfunctional voice disorder, a voice disorder that arises because of excessive usage of the laryngeal system. And that can result in problems like breathiness, hoarseness, all these things can be taken care of. So to address this, we first will have to address the velopharyngeal dysfunction. We first will have to address some of the other articulatory problems that they are having so that this will get resolved on its own automatically. So these are some of the common cleft type errors that we notice in children with cleft lip and palate. Now coming to the most important part, what needs to be done? And what is it that we have to counsel parents of children with cleft lip and palate? Now, this counseling varies depending on what is the age at which we are going to be seeing the child. My simple urge to all the members of this group here would be to predominantly focus on the early stimulation that parents need to give to their children. So it is very important to give them support and give them information regarding communication development to parents. Parents should at least be told that watch out for the productions of your child. See whether your child is producing the first meaningful word by the first birthday. And in order to facilitate that production, if you want children to start having normal language development, especially children with cleft to have typical language development, it's very important that the child has a stimulating environment in their houses. So we have to emphasize on normal parent-child interaction. It is so disheartening sometimes to see parents who come in for their first interview with us, probably by 18 months or sometimes 12 months at the time of palate repair. And when we ask them, how do you play with your child? They are sometimes taken aback and they just sometimes say, we don't play with them at all. So play behavior with children is something very it's such a remarkable process in which there can be a lot of stimulation that parents can give to their children. So parents have to be emphasized to have this normal parent-child interaction going. And in our culture especially, there are so many rhymes and so many playway manner in which we can facilitate sound production. Almost, if we try to imitate majority of the environmental sounds itself, all the speech sounds can be stimulated. Like, for example, if you take the bilabial sounds, you can do bow bow, as in the case of a dog bark, to facilitate production of bow bow. Or you can do pop pop with a bubble or with a balloon, that can be done. And if you're talking of the t sound, you can facilitate a t sound by saying ting tong, the doorbell is ringing. Or you can facilitate the s sound by imitating a snake going by, or you can say goes the snake. That can be used. The caw can be stimulated by using plenty of bird noises. So you can say that, no, look at the crow goes ka ka, or there's a parrot that goes ki ki. So most of the sounds that we want children with cleft to learn and produce, or even any other children for that matter, these are not something exclusive for just children with cleft lip and palate. We can use this for any of the other children as well, can be stimulated with environmental sound imitations and games. So these can be introduced by the parents to their children in a playway manner during the early stages itself. Once children with cleft are stimulated for their sound production, if they are able to do the sound production, then the vocabulary development comes on its own. We don't have to worry about it. If this stimulation is taken care of, the rest will automatically fall in place. If parents are encouraged to do the stimulation, and if they are able to learn to do the stimulation in an appropriate manner, we do have research evidence to say that the error patterns that we were talking of can be prevented as well. So the compensatory errors that we were talking, where they start producing sounds from the throat rather than producing it from the mouth, those kind of error patterns can also be prevented if parents are providing appropriate stimulation to their children. So we need to encourage parents to provide this stimulation in as much normal as fashion as possible in their daily environments. And we also have to tell them about the red flags there. So your child is more than 12 months of age, anywhere between 12 months to 18 months, and your child still has not produced the first word. You need to consult a speech language pathologist there. Your child is producing speech sounds, but the speech sounds are not coming from the mouth, but they are coming from the throat. You need to identify, because these problems need to be intervened early. Therapy for these problems should be started off early, because this is a behavior, so it's like a habit formation. Now we all know any particular behavior, if we are habituated to it for a long time, then it is difficult to correct and change it. But if I'm trying to intervene at an early stage and I'm trying to change that particular behavior, it's much easier to correct if you're not very habituated to it. So therefore, early intervention is very important. And if we have to do early intervention, we want parents to be aware of these red flags so that they can come back to us at an early stage to start off with therapy. And it's very important that the teams that are involved with cleft care and people who are dealing with children having cleft lip and palate in a very young stage, they have to be sensitized in order to make early referrals. So the key points sometimes are making them aware that there are some problems that can occur. And even if those problems occur, they can be corrected if we start off with the intervention at an early stage. So the team has to be motivated for this early referral. So with this, I would quickly sum up my presentation here. So we need to keep in mind that children with cleft do show delay in the development of language, especially in the development of the early words. There can be a slow onset of early words in children with cleft lip and palate. And once they begin speaking, we do find articulation and resonance problems in resonance errors in children with cleft lip and palate. And these problems can sometimes become worse if the patient is operated for cleft at a later age, or if they are operated inexpertly as well. Both of these are problems that we want to avoid. Early intervention focusing on speech and language behavior should definitely include parental empowerment, especially focusing on the language development and sensitizing them about the possible errors that can come up in children with cleft lip and palate. Correction of the structures is an important prerequisite for correction of speech deficits. None of the speech deficits can be directly tapered or directly targeted in speech therapy unless the structure has been corrected. So we need to send them for early structural correction. The early structural correction should be followed with early speech intervention. So early the structural intervention, better is the prognosis, and continuous monitoring of speech development is essential through the childhood period so that at any time we identify something that's going wrong, we are able to intervene it early. Thank you. And I'm ready to take up if there are any questions or points for discussion.
Thank you so much, madam. That was a really wonderful and very, very, lucid presentation. Really eye-opener for me, as well as I'm sure many of the obstetricians that are there on board. Would the chairperson like to make any comment? Dr. Ujwala, would you like to make a comment, or we can just proceed with the questions if there are any? Harsha? Harsha, have we received any questions?
Yes,
Hello.
ma'am. Yes, ma'am. Hello.
Yeah.
There are some questions which I have WhatsApped you. You can just ask from that sheet.
Okay, you put it in the WhatsApp?
Yes, yes, ma'am.
Okay. Okay, so first question is, what assessment tools do you find most effective for evaluating children with cleft lip, cleft palate as far as speech is concerned? I think few things Madam has already mentioned. Madam, is there anything you would like to add?
So when we're talking of evaluation, the key tool for a speech therapist is the perceptual evaluation. So we would just like to listen to the speech and go ahead with our evaluation process. Now, for listening to speech, we need a structured stimuli. You just can't randomly listen to some random statements made by the child and come to a conclusion. So there's something called as structured stimuli. So for the Indian languages, we do have for at least 6 or 7 of the Indian languages, we have structured stimuli that has been developed. If you go into the Smile Train website, you will be able to get all of them. Like, for example, to give you an example from Hindi, we do have structured sentences like Pappu Papita Pakdo, Tikku Ka TV Tuta. The Pappu Papita Pakdo is a sentence that's focusing on Pa. Tikku Ka TV Tuta is a sentence focusing on Ta. We do have specific sentences which we call as a structured stimuli. So it is very important that we use appropriate stimuli when we are doing perceptual speech evaluation, because I sometimes have even some of the people dealing with cleft lip and palate have sometimes gotten back to me and they said, I heard him telling this rhymes, he's telling this rhymes very well, or he's able to do numbers very well. So you don't listen to random speech stimuli and comment on their speech quality. So specific assessment tools in terms of structured stimuli will have to be used. That's one thing. Beyond perceptual evaluation, if we are suspecting velopharyngeal dysfunction, then we need to go in for instrumental assessments in order to identify the exact type and nature of velopharyngeal deficit there. So in such instances, we would use a nasoendoscopy, or sometimes a lateral view video fluoroscopy is used in order to identify those structural deficits pertaining to velopharyngeal dysfunction.
Okay. Thank you, Dr. Neeraj Joshi, for this question. Next question has come from Dr. Dhaval Patel. How to determine when a child is ready to begin speech therapy?
So it depends on what exactly we are talking as speech therapy. So speech therapy has two components to it. It's not speech therapy anymore. We would like to call it as speech language therapy, where we are working on speech correction, which is one aspect of speech therapy. And the other aspect is language therapy, where we are working on the child producing words. The child's quantity of output is what we are dealing with. Now, to start with language therapy, we can start off as young as anywhere beyond 12 to 18 months. We can start off with language therapy because we are focusing on trying to teach words to the child. Now, in a child with cleft lip and palate, I would normally maybe wait till the child is around 2 years or so to start off with this language therapy if I feel that there is still a delay that I notice in the production of words. The other part of speech therapy, where we want to deal with speech correction, that is where we want children to have learned or children to be producing some amount of language before we move on into speech correction. So normally speech correction or giving correction for an articulatory error or a resonance problem that we notice. So that is something that we start anywhere between 2 to 2.5 years of age. By that age, we are ready to start off with speech correction services. But if it is language, we can start off even younger.
Yes, ma'am. Thank you. Tiwari sir, there are more questions for you also. But first, I'm going through with the questions for Savita ma'am. So this question is from Dr. Gaurav Bansal. In your experience, how do recurrent otitis media episodes impact the speech outcome in such patients?
Recurrent otitis media is definitely a concern that we have to deal with. Articulation correction becomes a bigger problem when we are having these recurrent episodes. But what we do is we try to tackle, we work closely with the ENT professionals during that time and use the moments of non-active episodes in order to give our speech correction services. So when the child is having an active episode going on, it's very difficult to give therapy during that time because the feedback process is affected there. But during when there is no episode happening, then we use those moments for our speech therapy. So we need to work very closely with the ENT and handle it in that situations.
Okay, ma'am. Then Dr. Yogesh Taneja is asking, what diagnostic criteria do you use to assess the need for ventilation tubes in children with cleft palate?
So that's a decision that's more taken by the ENT surgeon than by us. We do look at the middle ear condition. If there is a retracted tympanic membrane because of recurrent episodes, then that is when we go in for Grommet insertion. We do not practice universal Grommet insertion in our scenario. So,
okay.
Yeah.
Okay, ma'am. Next question from Dr. Sanjay Sharma. What surgical techniques do you believe have the most positive impact on speech outcomes, and why so?
That's a very tricky question to answer. So as far as the palate repair is concerned, rather than going into the intricacies of what is a technique, because there are plenty of techniques and variations that surgeons use when we are talking of repairing the palate. As a speech therapist, what I'm concerned about is it something that is facilitating palatal movement? Has the soft palate movement been achieved? So is the palate lengthy enough? Is it long enough? And is a palatal movement adequate enough? That is what we need to look in for. Is there one specific technique that brings about that? I'm sorry, I don't think I will be able to answer that part of it. But as long as the method used is able to address these two aspects, something that results in a long palate and a mobile palate, then I would call it a good technique. Sometimes a good technique also done by someone without having much expertise can still bring about very unacceptable results. So it's not just the technique. There are a lot of factors that play there.
Yeah, I am sure. Okay, next question is from Dr. Vikram, who is himself an otolaryngologist. He is asking, how do you assess the success of a cleft lip repair in terms of speech intelligibility?
So speech intelligibility is a very global parameter that we look at. So speech intelligibility is basically a measure that tells us how much of a person's speech output is understood by a listener. So I'm listening to you speaking. How much of your output can I understand in terms of the clarity of speaking? So we are not talking about the language aspect here, but how clear is what a person speaking? That is what we call as speech intelligibility. In the recent days, we use the term speech understandability rather than speech intelligibility. It's the same phenomenon there, though. So we rate speech intelligibility on a 4-point scale from 0 to 3. And if a palate repair gives an intelligibility scoring of 0 or 1, it is considered as a good rating. So it's purely perceptual evaluation that we do. As far as speech therapists are concerned, this rating is not of much use for us, because when I say the speech understandability is 1 or speech understandability is 2, it could be affected because of multiple reasons. It need not be something that is specifically affected because of the presence of the cleft only. So for that reason, we do not use the speech understandability rating as an exclusive rating to look at commenting on outcomes. But if I have to comment on outcomes, then that is what it would be. A good outcome would be where somebody has an understandability rating of 0 or maybe 1 to some extent can be accepted still.
Okay, ma'am. Ma'am, next question is from Dr. Pavitra. What consideration should be taken into account when planning orthodontic treatment for a child who has undergone cleft repair?
So there are specific stages at which we go in for the orthodontic treatment, depending on whether the child is in, mixed dentition, permanent dentition. So we go in for that. So the necessity for orthodontic treatment is predominantly decided depending on the dental arches, the individual dentition, and the occlusion factors. Those are what are taken into consideration for orthodontic treatment. So they do not have a direct dependency on speech per se. The only instance where, should we go in for a dental procedure or a speech is a debate that generally happens between when children with cleft have to undergo distraction procedures. Do we perform distraction procedures first or velopharyngeal dysfunction first? So that is one aspect that has been debated a lot in the literature as well. And even in clinical practice, we do come across some of those scenarios. So if we are dealing with an older child who needs a distraction procedure and also needs correction for velopharyngeal dysfunction, then we give priority for the distraction procedure. The distraction procedure is done first, and then velopharyngeal dysfunction correction is taken in the case of older children. But otherwise, there is no one-on-one that we need to look in with regards to the orthodontic treatment or speech therapy.
Okay, ma'am. Next
Ideally,
question.
we would like to have brought about all the speech corrections completed before orthodontic intervention begins for children with cleft.
Right. Next question from Dr. Atul Jain. How do we collaborate to ensure optimal functional and aesthetic outcome for such patients?
So if functional part is predominantly dealing with Are we doing the corrections at the right age? That is one aspect. And to what extent are we following up the patient? So you cannot say the palate is repaired at 12 months, so the job is done and it is over. We need to have periodic follow-ups to monitor their development of speech and language, to keep a track on their dentition, to keep a track on their orthodontic needs. So the periodic follow-up is definitely required till a particular age in order to ensure that the overall development is attained there. So that is one of the key aspects that will help us, ensuring that the ultimate quality of life is good for those with cleft. So from my point, the key point there will be collaboration between professionals, ensuring that the team of professionals dealing with cleft have transdisciplinary knowledge in the first place, so that we are able to monitor them appropriately for the multiple needs that they have.
Yes, ma'am. Next question from Dr. Anita Kumari. Actually, more or less you have answered that how to monitor developmental progress in children with cleft lip, cleft palate, especially concerning speech and language skills.
Yeah, so that's the thing. We for language, we would look at their language development per se. What is the receptive language level? What is the expressive language level? And as far as speech is concerned, we look at consonant production. What is the inventory of consonants that they are producing? Are they producing it correctly in all particular situations, or are there any situational variations? Sometimes what can happen is they are able to produce a sound correctly in the middle of the word, but they're not able to produce it in the beginning of the word. So those kind of changes can be there. So we look for consonant production across all positions. That is the initial position, the medial position, and the final position. And we look for resonance and nasal air emission. So if we monitor for all of these things, the whole of speech and language development, we will be able to monitor.
Okay. One final question for you, ma'am. Dr. Manish Gupta, what referrals do you typically make for early interventions in speech issues related to clefting?
What referrals we make, in the sense, like as a speech language pathologist, what is the referrals that we make? Is that what the question is meaning?
I believe they probably mean what we as obstetricians or primary caregivers should refer to,
Yeah, so the primary caregivers, we definitely would like them to refer children with cleft. If it is children with cleft, we would like to see them as early as, at least at the time of their palate repair. So when they have had their palate repair, immediately after the palate repair or so, if they can be referred, then it is convenient to do a language evaluation and start following up with them. So that is the earliest point of referral that I would say. At least at the time of palate repair, a consult with a speech language pathologist is recommended.
Okay, ma'am. Okay, thank you. Thank you, madam, so much. Dr. Tiwari, I have some questions for you. Are you there? Dr. Rajendra Tiwari? Rajendra, sir?
He's there, ma'am. But
Hello, hi, I'm there, ma'am. I'm there.
Yes,
much
sir.
there. Thank you very much.
Okay, sir, few questions for you. Dr. Meera
Yeah.
Sharma is asking, what are the key fetal anomalies you prioritize during an obstetric ultrasound, and at what gestational age do you typically screen for them?
Actually, regarding the key anomalies, I have already mentioned in my slide, which has been given in the medical legal book.
Yes, sir. Yes, sir.
Another is priorities. There are different annexures given for performing MTPs after 24 weeks of pregnancy. Those annexures are available online also, on the website also, as well as in the act also. So those online, those annexures should be there with the obstetricians, so that those anomalies should be properly screened and those anomalies fit in that indications. If those indications gross anomaly, मतलब वो anomaly अगर fit 20 to 24 इसमें है, तो annexure में है तो ही कर सकते हैं. Cleft lip is not a gross anomaly. So there are certain annexures for musculoskeletal, CNS, cardiovascular. So those annexures should be read properly, and those prioritization for those should be done.
Right. Okay, sir. There is one question from Dr. Mukta Raite. In your experience, how often do medical legal issues arise due to missed or delayed diagnosis of fetal anomalies?
See, I am a part of negligence committee of our district. At least in 1 year, one case is coming in a Palghar district. So it is not
Okay.
uncommon for the, yeah. So
So
uncommon for
if
the,
Palghar
either
is
for
facing this
misdiagnosis
problem, then
or
I
for
guess,
cognitive errors.
yeah, I guess the bigger center, bigger cities must
Mumbai,
be
everybody can
facing it
face
more
this
often.
problem. Yeah,
Yeah,
expectations of the patients from the sonography, or for that matter for the doctor or imaging technologies, is high increased. तो कुछ भी miss
right.
होता है तो they are not taking lightly.
I know. Dr.
One more
Nikhil
case from
Mahadar has
Nagpur I
asked.
didn't mention. One more case from Nagpur, similar case was there. In that also around 35 lakhs compensation was awarded recently.
Sir, here I would like to ask one question on my behalf, that if there is a anomaly that is missed by the sonologist, patient is primarily mine as an obstetrician, so I am interpreting a report which is given by the radiologist. But still, am I held responsible if anomaly is missed by radiologist?
The case I mentioned, sentinel scan versus Sridharan. In that case, actually, gynecologist had referred the patient to the sonologist. The patient was referred after 22 weeks. It was a routine anomaly, routine scan. She had not written anomaly scan specifically. So on that basis, radiologist told that the patient was referred only for the routine scan for which we are charging. That has been mentioned in the judgment. उसके लिए हम लोग 600 charge करते हैं and we give less time. And if it is an anomaly scan, then we give more time and we see it more specifically, like targeting all the organs. So since only routine scan was written, we don't target on that. उसमें फिर कोर्ट बोला कि वो पैथोलॉजिस्ट का एग्जांपल दिया कि सीबीसी देखने के लिए बोला और उसमें मलेरिया पैरासाइट मिला, तो आर यू नॉट रिपोर्टिंग मलेरिया पैरासाइट. Similarly, if you are doing routine sonography and if you come across some anomaly, it is your duty to report it to the concerned doctor and the patient. लेकिन उसमें ultimately the compensation was awarded. 1.5 crore compensation उन्होंने claim किया था, 15 lakh कोर्ट ने award किया.
So even the obstetrician, although obstetrician has not done the ultrasound, can also be held liable.
It is considered as joint responsibility, and the compensation awarded is supposed to be shared among all people. जो भी उसमें involved है, gynac है, radiologist है, सब share करके भरो.
Okay. This next question is, sir, Nikhil Mahadar has asked, what steps do you take to ensure that the ultrasound reports are legally compliant and thorough?
Vis-a-vis printed reports, many people write that this report is not for medical legal purpose, but that doesn't save them, because any report issued by you is a legal document by per se, without saying. So जहाँ तक report देने की बात है, there is no any protection can be offered by writing anything. Only thing is that all the parameters which have been expected by us, PCPNDT का जो बुक हम लोग रखते हैं हमारे क्लिनिक्स में, PCPNDT चे कॉपी होतो है ना आपल्या याच्यामध्ये, that has given what is expected in level 1, level 2 and level 3. So that should be read sometimes, and we should see what parameters are required for. We are doing mostly many obstetricians, they are doing level 1 and level 2 scan. उससे आगे नहीं जाते, level 2 भी नहीं करते, level 1 ही करते. Few obstetricians they do anomaly scan, and very few go for the 2D ecography and level 2 etc. fetal medicine. So हमारे level 1 के scan में what is expected has already been clearly mentioned in that booklet, which is already available in our clinics, which is mandatory to keep 2 copies. We are keeping it, but nobody opens it. Open it and see what are the parameters required and follow it. I have got the copy, I can show you. Everybody has got that copy. आपके पास सबके पास रहेगा वो. 2 कॉपी हम लोग रखते हैं ना मैंडेटरीली. इंस्पेक्शन के लिए आते हैं तो कॉपी मांगता है.
Okay. Where there may be a discrepancy in findings. Hello, can you hear me, sir? How do you manage cases where there is a discrepancy in findings, especially if it could impact patient outcome? Frankly, even I have not understood whether there are 2 reports having different opinions or what exactly. Dr. Gundewar has asked this question.
So actually discrepancies can be there, but in that case already, as the AUIM has guidelines said, in that case we should either review ourselves. उसमें लिखो review after 2 days, whatever, if it is not urgent, or take a second opinion from another radiologist or gynecologist, or go for some another imaging modalities. Like neurological elements are not well diagnosed on sonography. So many people are doing MRI of the pregnant woman, to see the anomalies clearly. So adjuvant imaging modality should be adopted, or you yourself should review it, or you should take second opinion without hesitation in that case. And nowadays it is readily available.
And one last question, sir. What ethical consideration do you keep in mind while performing ultrasound and informing patients about their results? Ethical
Informing patients,
consideration. I don't see.
considerations
Maybe
are not
maybe
specific
I
for
don't know
sonography.
whether the person asking means that whether the radiologist should talk to the patient, or the primary referring doctor should explain the report. What is your opinion?
Radiologist, if I am a radiologist, definitely I should refer the patient to the primary doctor who has referred, and he or she should explain the report to the patient. In fact, if I am so much concerned, I should speak with that primary doctor, because that primary doctor has certain notion in his mind, and yes, he is well known about the history and everything, so he can explain that properly.
Very true, sir. And it always is better if there is only one point person who is talking to the patient. Moment two people speak to them, there are bound to be some differences in what we are explaining or what the patient perceives, and then that creates scope for
in fact I won't name, but I had one radiologist in there is some lighter note. There was a radiologist when I used to in Gujarat, जब मैं काम करता था, so that radiologist used to use eat pan masala, और वो हमेशा पान मसाला खाते थे, और पेशेंट कुछ पूछता है तो कुछ नहीं बोलते थे, ऐसा ऐसा इशारा उधर जा, और बहुत ही पूछा तो जाके वो पान मसाला थूक के आके मैंने तारे तारे गायनेकोलॉजिस्ट ने पूछ, इतना ही बोलते, फिर से पान मसाला खाते थे। तो उनको मैंने बोला ये क्यों, तो ये मेरे को हेल्प करता है, मैं बात ही नहीं करता, मैं भेज देता हूँ पेशेंट। ही वाज वेरी पॉपुलर। तो actually on lighter note, it's better that radiologist refer to the primary doctor. He is saved of his headache also, and he is not because he is not doing the proper history and what management is being planned by the gynecologist. अभी बहुत बार ऐसा होता है, मेरे साथ भी हुआ है, मैं IUI प्लान कर रहा हूँ, फॉलिकुलर स्टडीज के लिए भेजा, और रेडियोलॉजिस्ट ने बोला हाँ फॉलिकल रप्चर हो गया, नो यू प्लान द इंटरकोर्स। दूसरे दिन IUI के लिए सीमेन नहीं मिलता है, because he doesn't know what I am planning. So I am of the opinion that primary doctor should be consulted, and he should be the point of discussion about the report.
Sir, I want to ask. Hello, sir. Am I audible?
Yeah, sure.
Hello?
Yes, Ujjwala, you are audible.
Yeah, I want to ask.
Not visible, but audible.
Routine level 1 obstetric sonography. Suppose anomaly is missed. Is it punishable? See, it is not.
The same thing. It is not punishable. It is a consumer case, civil case. It is a civil case. But in that also, all those 4D should be satisfied. It is within your scope or not. Whether you have derelated that, whether that has caused damage and or death. If all these 4 questions are satisfied, the court will order the compensation. Otherwise, nothing will happen.
Yeah, one more question I want to ask. Can sonologists do any sonography referral from, not from obstetricians or any consultant's name, any obstetric sonography only referred by the name of hospital? Is it allowed? Can any sonologist do this?
No, if some another hospital, some doctor has referred this, it is actually allowed. If directly done, it can be done, but it is not explainable when it goes to the court of law, because they are not primary treating doctors. Tomorrow court of law can ask them why you advise it, because you are not treating the patient. Suppose I am a pure radiologist practicing, और bleeding patients को मैंने advise किया और कुछ आया missed abortion, I am not going to do any treatment on that. So it is not justified to advise,
no, sir, it's not
but
like that.
Can advise because manage कर रहे हैं.
No, sir, my query is not that. My query is, a sonologist getting a referral sheet for obstetric sonography, where the referral is not any doctor's name, but referred from XYZ hospital.
It is in the hospital name. It is not allowed because that column has specifically mentioned the doctor's name.
Yes. Yeah, because
even I get such reports from government. I get some government hospitals. Even I get, because doctors keep on changing now over there. So they write only medical officer. तो मैं लिखता हूँ MO SDH, MO civil hospital. ऐसे लिख के मैं जाता हूँ, because doctor का नाम तो जरूरी है, mandatory है as per the provisions mentioned.
Sir, I believe Ujjwala is asking because there are so many hospitals which have no MyBap, and some.
Yes. And I'm on PCP.
Some hospitals are run by Ayush people and
yes. Sir, I'm on PCPNDT committee. So every time we feel that we are allowing this, whether we should make the rule like this, whether we should send notices to such hospitals like this. No.
Ideally, hospital should mention the name of the doctor who is referring.
Okay. Thank you, sir.
Yes. Yes.
Thank you, sir. Thank you, sir.
Thank you.
Tiwari,
Thanks a
sir.
lot.
Thank you, Savita,
Thanks
ma'am.
a lot.
And thank you, Harsha and entire Smile Train team for a really wonderful webinar. Both speakers did a great justice to their topics allotted. And I think we had a very, very nice and stimulating session with lots of queries answered. So thanks to both of you, and over to you, Harsha.
I would also like to thank Dr.
Thanks a lot.
Tiwari and Dr. Savita for their engaging presentation, and your contribution to this event was invaluable, and also the coordinators, Dr. Supriya and Dr. Monica ma'am, for arranging this event and making this huge successful. And thank you everyone who has attended the webinar so far.
Thank you so much, and wish you all a very, very happy Diwali.
Happy Diwali to everyone.
Wish you all the same.
Thank you.
Thank you.
Bye.
Bye.
Okay.